Um, yeah. I know it is AT&T. They suck sometimes. It really drives me crazy. Okay, so those are the symptoms. And yes, that's the test question. What is the goal of treatment? Because there's no cure for Parkinson's, and the treatment will be lifelong. And so the most of the treatment, by and large, is trying to increase the amount of dopamine in the person's brain to reverse this, try to rebalance the scales. And so there's different ways to try to increase dopamine, and those are our three medications. Oh, Natalie, pill rolling is one of the types of tremors that a patient will have with Parkinson's, in which their tremor is that it looks like their thumb is rubbing against their first two fingers, almost like they have something in their fingers that they're rolling around. And that's what they call it, pill rolling. That's kind of a typical Parkinson's tremor. So here are our three medications, and they're really meant to increase the amount of available dopamine. So levodopa carbidopa is actually a synthetic dopamine. Um, Pramipexole is a dopamine agonist, so it acts like dopamine. And selegiline stops breakdown of dopamine in the synapse so that dopamine is around longer. So that's the whole goal, is to try to increase the available dopamine and rebalance the scales. And sometimes these medications can be taken together. Levodopa carbidopa. Levodopa is actually the synthetic dopamine. Once it crosses the blood-brain barrier, it becomes dopamine. But in order to prevent it from being metabolized before it gets across the blood-brain barrier, carbidopa is attached. You can't take levodopa by itself, or it'll never be able to cross the blood-brain barrier and be dopamine. It takes a long time for the person to feel the effects of the medication. It can take up to 6 months. It's a medication that's taken by mouth, but, and this is key, should be avoid high protein foods at the time that you're taking the medicine, because that'll decrease absorption. The other issue is that um, you have to, it's really hard to manage levodopa carbidopa sometimes, and people will have times where the therapeutic level or the level in their blood drops, and so they might have been feeling great, and all of a sudden they feel the muscle rigidity again and have symptoms that are stronger again, and that's called the on and off effect. So um, levodopa carbidopa can cause nausea and vomiting, so it has to be taken with food. It can cause some harmless darkening of the urine and sweat, so you just let the patients know that they don't have to worry about it. Um, it can lead to orthostatic hypotension, so you have to be very careful with these patients that they get up slowly. Um, they're already a falls risk because Parkinson's changes their center of gravity and makes them lean forward, so they're already at risk of falls. So we have to be careful. And especially in the beginning, there can be an issue with something called dyskinesias, which are tremors, um, head bobbing, and like grimacing of the face or smacking of the lips or sticking out your tongue, which can be distressing symptoms. I mean, you're taking the levodopa carbidopa to get rid of symptoms that are similar, like different types of tremors and grimace and muscle rigidity, and then you end up getting different ones, which can be hard for people. Those particular tremors don't change the person's ability to care for themselves, but they're still distressing. So they should wear off as the patient is taking it, but they should know about that. And there's multiple cautions. Um, the contraindications to taking levodopa carbidopa are glaucoma, melanoma, which I'm not sure why. I don't know if it makes you more sensitive to the sun. It didn't say that. Or suicidal thoughts. But it could potentially you have to be cautious with pretty much every single health problem. It's not the easiest medication to take. And now I'm looking at this and seeing that some of the Parkinson's medications are missing from my slides. I just don't. I mean, life is not going well. So we'll switch to Alzheimer's and then take a break so I can find out where those slides went. This is going to be quite the day. So Alzheimer's, because there are two more medications that we have to look at for dopamine, and I'll have to figure out what happened to that group of slides. Alzheimer's disease is the other neurodegenerative disease that we're going to talk about. And what happens with Alzheimer's is that the damage is primarily it could be within the whole brain, but it starts in the frontal lobe. And there's damage to the nerves themselves where they become tangled. The problem is that some of the proteins that keep the nerves straight develop some kind of defect. It could be genetic. There's not we don't always know the cause of all cases of Alzheimer's, but for some reason the proteins that keep the nerves straight aren't made correctly, and then they get all tangled up. So the patient starts to have breakdown of those nerves that are tangled. So you'll see plaques and what are neurofibrillary tangles, and then the brain gets smaller essentially because the nerves start to get broken down. So this is a degenerative disease. It starts with the patient having issues with short-term memory, maybe some mood changes, some executive function changes, like it's harder to maintain your checkbook, or it's harder to remember when your doctor's appointments are. But you can still function, but slowly the degeneration will increase where people are no longer able to take care of themselves and have to be taken care of by others. And then it can be that they become more and more confused. And the last stages of Alzheimer's, the person is unable to care for themselves at all. Um, People don't generally die of Alzheimer's disease, they die of something else because they've stopped being able to care for themselves. Maybe they get a urinary tract infection or a pneumonia or something like that. So this is a disease of the frontal lobe. And what we said when we were talking about Parkinson's is that the main neurotransmitter of the frontal lobe is acetylcholine. So if we're breaking down these nerves in the brain, there is less acetylcholine. And so one of the treatments is to try to increase available acetylcholine for nerves that work in the brain. Maybe that'll help with memory and function. And so the medication that is used, one of the medications that is used, is actually a cholinergic drug. It's meant to work in the central nervous system only, so only in the brain. It's not supposed to affect the parasympathetic nervous system or the skeletal nervous system, the somatic nervous system. That's in the periphery, so it's only supposed to affect the brain. Although, and it's pretty good at that. There are sometimes some issues, but it's only supposed to affect inside the brain. And it is similar in its action as the drug that we used for myasthenia gravis. So with inside the brain, we have one nerve, which is that presynaptic nerve, and there's the synapse. And then because this is inside the brain, the next thing is another nerve that'll have receptors on it. And a stimulus will be generated, and any stored acetylcholine in that nerve will be released into the synapse and then will interact with receptors and cause the next nerve to fire. Eventually, in normal processes, an enzyme will come in. If we're talking about acetylcholine, the enzyme is cholinesterase, to break down the leftover acetylcholine in the synapse so that this um, stops and there's rest of this next nerve so that we're ready the next time we need it. If somebody is having degeneration of nerves, then this medicine is actually going to block cholinesterase. So acetylcholine stays in the synapse longer and can interact with the nerves that are functioning. That's the whole point. So it's helping acetylcholine work better in the central nervous system, which makes it a cholinergic medication. Its effects are pretty modest though, and it's best if you start it early in the process. If the patient is in the later stages of Alzheimer's, it does not help very much. So it's the person should, if they're noticing memory trouble, consider using this medicine. It can leave the person with a little bit of nausea and vomiting, especially on an empty stomach, so it is okay to take with food. It can cause insomnia, so it's better to take in the morning. Other common side effects are dizziness and headache. It can make the patient's heart rate get lower, so that is unfortunately partly because it's a cholinergic. It's possible that there is some stimulation of the parasympathetic nervous system, especially in terms of heart rate. And so if the heart rate gets too low, the patient could faint, which obviously for a dementia patient, an Alzheimer's patient, is not good. And for some reason, it is not known, there is an increased risk of GI bleed when this medication is taken with NSAIDs, like ibuprofen or Aleve or aspirin. They might have an increased risk of GI bleed. So if they were complaining of an increase in stomach pain or black tarry stools or things like that, then we would have to worry about them. The other medication that is used for Alzheimer's disease is something called memantine, which is Namenda is the other name for it. Memantine is called an NMDA receptor antagonist. For Natalie, for donazepam, the last part for donazepam is regarding its interaction. Donazepam and NSAIDs like aspirin, Aleve, ibuprofen, there's an interaction between those medications that increases the risk for GI bleed. So anyone taking donazepam should really stick to Tylenol or acetaminophen if they have mild aches and pains or headache instead of NSAIDs to decrease that risk. Memantine, as I said, is a NMDA receptor antagonist. NMDA is a receptor that when it's activated increases the amount of calcium that goes inside the nerve, and calcium inside the nerve can actually hurt it. So if more calcium goes inside the nerve can die. So if we try to stop that from happening, we could hopefully decrease nerve damage. And memantine and diazepam, which is actually Aricept, those medications are usually taken together so that we can try to hit Alzheimer's in two ways. This also can cause nausea and vomiting, so it's given with food. And if the patient has underlying liver or kidney disease, the dose should be lowered because of the changes in metabolism and excretion. We have dizziness and headache, again the same as donazepam, and increased confusion, which is unfortunate because we were trying to prevent some of that stuff. And so I know if you should notice that we get dizziness, possible syncope, and dizziness and possible increased confusion on a patient that's already having issues. So we have to really watch them so they don't fall or have a different problem. And the other problem is constipation. So take a little bit longer of a break so I can figure out where those other two medications are for Parkinson's. So if we could come back at 10:45, so I can be sure that we get all the information for Parkinson's, and then we'll move on to seizure medications, um, and hope that everything starts to sort itself out here. I don't know what um, sort of imp or elf is taking over this class right now. Oh, sorry. Well,
Yeah,
hopefully that'll get better.
it's cutting out
My
for me
voice
too.
is
I didn't
cutting out.
hear what time you said.
Oh, sorry. 10:45. Well, maybe I'll log out and in again. Maybe that's because I cut out before. 45.